Hi, I'm Dr. Jennifer V. Brown, your stroke specialist, and today I'm giving you pearls of wisdom regarding how to modify an ankle foot orthosis. AFO modifications may be required when there's normal wear and tear of the ankle foot orthosis and or there's a change in body size and function. The most common modification is the replacement of the straps. I do not use rigid traditional Velcro straps. I use elastic tension spandex material. The bands come in different tensions made by different manufacturers, and I change those straps out based on muscle tone, strength. If the strength is improved, they get something more elastic. If there is more stiffness, spasticity is kicked in, they get more rigidity. How I put it on the AFO, sometimes it doesn't always go straight across the top of the leg. Sometimes it goes in a diagonal to facilitate external rotation of the tibia versus internal rotation of the tibia. Um, and when I am applying the strap to the foot at the ankle, I always start laterally and go medial to the towards the big toe if there is over supination. If the foot is overly pronated and it's causing valgus knee pain, sometimes I start at the instep of the foot, the medial side, and move it laterally to raise the arch. Sometimes people are just given the wrong ankle foot orthosis, as you can see here in this bottom picture, or they have a lot of edema and swelling. And so the brace is no longer serving a purpose. And so you just have to change it out because of changes in the person's body. The key thing is we need to do a full physical therapy examination before we give a new brace and make sure during the subjective history you hear what the person has to say about the AFO and their ability to use it, wear it for fit and function, as well as getting the opinions of the caregiver if that is appropriate. So, the number one reason why I make modifications to an ankle foot orthosis is because the strength changes. And that means the strength has improving. Why? Based on lesion location, severity, and size, I've started treating all of my individuals with stroke differently. They just don't get the same regular traditional stroke rehab exercises. It depends on lesion location and what I'm doing, whether open chain, closed chain. Gait is highly eccentric. I give a lot more eccentric exercises. If they have extensor synergy patterns, they're doing less open chain work, more closed chain, loaded eccentric activities, and more things in the developmental sequence where the hemiplegic lower extremity stays in weight bearing. So in this example, you can see that this person started off with a very tall ankle foot orthosis and had the anterior walls coming more medially. I wanted to limit a lot of tibia rotation and forced pronation, so we had that lateral wall. But after a month or two of rehab, look how low this ankle foot orthosis is. All right. And he's a tall cup of water. In that fourth picture, he's able to stand up and you can see his anterior tib, his lateral wall, and even his calf muscle being activated. That's because I didn't give him a restrictive Velcro strap across the top of the AFO. I allow for tibial movement forwards and backwards, as well as internal and external rotation. So this is how an AFO changes over time due to strength changes. This is the same AFO. He did not get a new one. Another reason why AFO modifications may be needed because of changes in range of motion. So if you look at this AFO on the left, look at where the P light, that inner lining is ending. but also look at the AFO. It's set in plantar flexion. And so I allowed her tibia to come forward. She did a lot of squatting, a lot of kneeling, a lot of sit to stands for her exercises. And when she did sit to stand, her less affected leg was in very different positions, in front, back, out to the side, up on a shoebox. Um, she tried to stand in tandem. I had her stand in tandem, right? But she had gains in her ankle range of motion. And I needed to take up the space in the back of the AFO as opposed to heating it up and making it the shaft wall, the vertical part, move forward. And so you can see how I added more P light there. And she did really well. So when it was time for her to get an ankle foot orthosis, I had the justification, and we just couldn't keep adding more P light into the back of that shaft. It became uncomfortable after a while. And so we just wrote up the letter of medical necessity, and we had all sorts of measurements to our advantage to justify getting a new AFO. So, what are some clinical pearls of wisdom from modifications? Documentation matters. You have to measure changes, right? And you have to measure the changes at the body structure function level as well as the activity level. And when you're doing these measurements and documenting changes, take pictures and video and send that in to the insurer. So, I'm measuring strength, I'm measuring it isometrically, concentrically, and eccentrically using the upright motor control test, as well as the traditional manual muscle test. I'm looking at range of motion. I'm measuring R1 and R2. The first and last measure feeling, or you're measuring resistance. R1 is the first feeling of resistance. R2 is your final feeling of resistance. I'm measuring skin changes, the chafing, the rubbing, edema, interstitial edema. When is it? How much it is? Morning, late afternoon? How long were you on your feet? Did you sit? Did you elevate your legs? I give them a piece of paper to document all that, and they bring it back to me. Again, this is the evidence that we're using to justify for a change in an AFO. And then I look at activity levels. Some of the things I measure is sit to stand. I just don't say the number that they did or the time, like 5 times or 30 seconds. I say the quality. Did they have to use a hand? From a side view, how much of their trunk was going forward in the horizontal component. Sometimes I split the time, how long it took them to get vertical and why. It's usually a weakness in the calf and the quadriceps and the gluteus muscles for that lift off. And I look at gait speed as well as gait quality, and I relate it to their ADLs, their work, or their leisure activity. People want to get back to work. So, in order to get back to work, they may have to do a task in a certain amount of time. I am simulating those tasks that they have to do to work. And most people don't go to work for a paid job, but people have to want to do volunteer work. And so I do the same thing for their leisure or volunteer activities. And I use all of this information to put in the letter of medical necessity so that the insurance company can pay for the modifications and or a new AFO. And so for the final clinical pearls of wisdom, this has to be a shared decision making approach. Okay. It has to be a team approach. It has to be person centered. So that's the patient and client first. And then the caregiver, if there's one involved. And then me as a PT providing the relevant data, and then the orthotist looking at that data and saying, well, if they're standing on the feet and they're having aches and pains here, maybe we need to add more padding here or make the AFO thinner here. So it's everybody's expertise and their experiences coming together to make the best AFO for how they're functioning at the time. Remember, I am your trusted source for all things ankle foot orthoses and neurorehabilitation. And these are the references. Evidence-based practice for the best clinical practice. Thank you for listening to this video. Don't forget to like, share, and leave a comment. Bye-bye. See you next time.